All right, welcome back to Bayou Time. I'm Martin Falls with Dr. Craig Walker. Once again, you've seen him on the program many, many times for various discussions. Well, tonight, he is the clinical editor of Vascular Disease Management, and we're talking about venous disease, and we've started the discussion. We're going to get more in depth on it now, but if you do have a specific question and you want to call up, there's a number on the bottom of the screen, 879-1231. If you're in Mandeville, Gretna, wherever you're watching us, you can call up and your identity will not be known, right? So there we go. Now I want to turn the attention back to Dr. Walker. So many times we've talked on the show about spider veins and varicose veins, and my God, how many times do we hear somebody saying they have varicose veins and they're so ugly and they don't want them? But what is a spider vein and what is a varicose vein?
First off, varicose veins are the big rope-looking veins that you see sticking out in the lower leg. And these are veins that have lost their valvular function, and so they swell up, and sometimes they even clot. This is a picture of a varicose vein. Now, if you look below with the fingers, those are varicose veins below, you see these little bitty purpley discolored veins below. Those are spider veins. And spider veins are much more of a nuisance. Women hate them because they think they look ugly. Women like to look pretty. And so they're more cosmetic. Varicose veins, on the other hand, actually are associated with a lot of pain, particularly in occupations where people have to be upright, like hairdressers or barbers or people like that are standing up for long periods of time, musicians. Those could really hurt because they're putting pressure on the tissues from the inside out, and they hurt and can actually, if they get really severe, can cause ulcers to occur.
So varicose hurts, spider doesn't hurt?
Typically does not hurt, it's just ugly. Okay. But it's often a sign that the valves are leaking from above. So often we use this as a clue because, again, we can have all sorts of problems. We have the leaky valves, but there's also a situation where we can have compression of veins, and they can actually block up. And so if a vein totally blocks, it's really difficult to get blood back to the heart with low pressure if there's an obstruction.
I want to bring that picture back up, Jay, if we can, because I want to ask Dr. Walker a question. The varicose to the left, the spider veins to the right.
Right.
Do they have to coincide together, or can you have one without the other?
You can absolutely have one without the other. You can have either one. Where they are is important. In this case, these are around the knee in this case. The further down they are, the more we get concerned with some of these. But really big veins up in the thigh can be a big problem. And we have different sets of these veins. You understand, in the venous system, we have veins that run right under the skin, so we call those superficial. And we have those that run down deep near the bone, we call those deep. And our body functions well with either one of them working well. And in fact, sometimes if one set isn't working well, it's better to get rid of it and make the blood go into the deep vein system rather than let it pool. But if you've ever watched someone with bad vein insufficiency, since blood pools in the feet, and since there's hemoglobin or iron in the blood, it will actually stain the skin. The skin will turn dark brown. So if you've ever seen someone where the calves are a very dark brown color versus the rest of their skin, it's a good chance they've got vein disease.
That's interesting. Never quite heard that before. Jay, let's bring up the symptoms, because I want to ask Dr. Walker for our audience tonight. A lot of people watching, there's the symptoms of venous disease, and let you go through each one of those.
Yeah, venous disease is swelling or heaviness in the legs, particularly worse when you've been upright, because that's when gravity is fighting the return of the blood. Calf pain or cramping, once again, most commonly when you've been upright. Visible rope, varicose veins or spider veins. Skin problems or discoloration. Dry or weeping eczema. For instance, many people with skin wounds will keep having material pour out of those wounds, and the wounds won't heal if the venous pressures are high. It keeps leaking that very clear straw-colored fluid that sometimes you'll see when you scrape yourself. And then finally, very worrisome is a leg ulcer. A leg ulcer from a vein is a big hole in the skin, and since the skin is the first barrier to infection coming in, once you develop these, you can get infection, that can get into your bone, it can get into your bloodstream, and that can be life-threatening.
Now, we've all seen the commercials, eczema or psoriasis, but so eczema is associated with what we're talking about.
Well, leaky material coming out is. Typical eczema is a different story.
Okay.
When we're just speaking of the dermatological problem, but when we're looking at this serous fluid leaking out of a wound, that's often associated with very high venous pressures.
So I guess the eczema is giving it a conduit to get out
That's right.
of the
That's-
body.
that's
so,
right.
So to speak.
That's
That's
right.
very interesting. Now, I know y'all have developed a lot of venous services at CIS. And over the years, I have to be honest, it seems like y'all have broadened your horizon, looking at different things, because you've learned a lot more about different areas as you have researched what stuck 25 years ago might have changed.
Sure.
Quite a bit. And I know y'all have opened, you weren't, you didn't have tunnel vision. You let it go where it went.
Well, we had to. You know, we became one of the biggest referral centers for vascular disorders in the whole world. And a lot of that was arterial. And so we really worked on that. But some of these patients had no arterial problems at all. It was all venous. And so we had to morph into this. Simply, there was the need. And as I said before, circulation is the entire circle. That's the base word of circulation. And so we have to be able to treat all those components.
So would somebody normally would come to you and say, I have a heart problem, or I feel like I do? You would go look all the way around through the whole gamut to see where it started at.
Yeah, you at least would ask questions and do a full physical exam. Understand that to simply listen to a symptom and listen to the heart is not a good exam. Often there are clues in the eye that a person may have a problem. There are skin changes that a person may have a problem. Peripheral pulses may tell you about a problem. Leg swelling tells you about a problem. We have to assess the entire patient because the circulation goes around the whole patient. It's not just limited to the heart itself or to the brain or to any one area. You really do have to assess the whole patient. Understand, on the arterial side, people with blockages in the heart are much more likely to also have blockages in the arteries going to the brain or in the arteries to the kidneys or in the arteries to the legs. People with vein problems are much more likely to have other problems. If you have slow flow, you're much more likely to get clots in those veins that can break free. So it is very important in terms of good contemporary medicine, and I certainly teach when I'm teaching courses or teaching classes to assess the whole patient, not just a given problem.
Let me ask you this, just in talking with you, my mind's working. If someone has varicose veins or spider veins, is that a precursor that they're going to be in deeper trouble as they go along?
Not always, no. It may stabilize, and sometimes it's not a big problem. Sometimes we treat this just with compression hose and elevation, and their symptoms go away. And if they're not bothered by the way that looks, that's fine. There are some people who don't really have pains, but they just hate the way it looks and want it dealt with. And then, of course, you have those people who have progressive insufficiency. No matter what you do it, if you don't treat them, they're at real risk of losing a leg.
Right. Let's talk about some of the equipment that y'all, I remember filming shows there many, many years ago, and the equipment has changed so much
For sure.
that you could, let's start with the duplex ultrasound.
Sure. So first and most important piece of equipment is a doctor that takes a history and physical, of course.
Okay.
And I can't overemphasize the importance of that. And for a patient to communicate that they've experienced problems, because we may not look if we don't hear that legs are swelling or hurt. But duplex ultrasound is just an ultrasound. It's using sound waves, and just like a depth finder in a boat. And we're looking at the vein. We can see the vein, but by using the duplex or the signal, which you can hear if you've ever heard a train pass by, it makes a different sound as it's passing by you. That's duplex, that's Doppler shift. By using that, we can determine if blood is coming at us or going away from us. Now, in the veins, blood should be going in only one direction. If it's going in both directions, the valves are leaky, and that's how we pick up that they're leaky. We also can often see clot. Clot shows up in that if you push the probe, since clot is hard, the vein doesn't collapse. And so it just stays there. And so we don't see the blood moving when we squeeze the leg. Once we've made the diagnosis, we also have CT that can assist us in the diagnosis. Once we've made the diagnosis, though, let's say this is a varicose vein that's causing the symptoms. We have the capability of going in and treating that. We can use laser, we can use radiofrequency, we can use sclerotherapy, where we actually inject the material into the veins. That's how we would treat most of the spider veins. We can make them go away where you couldn't see them at all.
What do you inject in there?
Polypropidopanol. It is something that when we inject it, it displaces the blood and it makes them scar down and you never see them again.
Okay.
So you just don't see them.
So what does it, sort of harden it a little bit?
Doesn't harden it at all. It just makes them scar down.
Okay.
It's a foam that goes in and displaces the blood so you don't see it. As you're injecting, you can actually see it turning white and it scars down, they don't see it. And
that's neat.
You know, the beauty of this is it's not a painful procedure. It's something that's done in the office. Patients leave the same day, and typically they will say they have a little aching there for a few days, and then that's it.
What's a typical treatment do you do? 5 veins, 10, 100?
Yeah. No, we typically take on one big superficial vein. Let's say we have very severe leakage. The most common veins that leak, if we're doing venous varicosity, are the greater saphenous veins. Those are the ones that run on the inside of our legs. Greater saphenous veins, we would typically treat one of those and use some sclerosant below and see what that does, you know, at that point. Sometimes you have to treat both sides, both legs, and in some people, very rarely, you'll also have to treat the small saphenous vein, which it runs on the outer surface of the leg or the sides of the leg, rather the inside of the leg. But that's rare. Usually it's one of those greater saphenous veins that we treat and make go away. Those are the ones that have leaky valves. Now understand, those that are blocked with clot, that's a different treatment, a different story.
You know, I sort of chuckle, but it's serious, but we all grew up and saw relatives on the porch, you know, as we sat there and talked, and it seemed like the whole culture experienced varicose veins or spider veins, but are they all treatable, or just some, or some more stubborn than others?
Yeah, they're all treatable. The question is, do all need treatment, is the second
Good
part.
point.
Not everyone needs treatment, and I certainly would never advocate that they all need treatment, but some clearly benefit dramatically with treatment. And of course, those that people cosmetically just can't stand. I mean, there are not many women, particularly younger women, who have varicose veins that are happy about having them. See, these can be related just simply to the hormonal changes they had with pregnancy. They can be related to the fact that during pregnancy, the baby was compressing on the vena cava, and so the pressures went up, and that affected the valves. It is about 3 to 1 more common in women than men.
That's what I was going to ask you. So women get it more,
Yes, they do.
but men do get it.
Oh, yeah. Both get it severely.
Oh, do men come to you overly concerned too? Or are they as much into the cosmetics, or do they look at more of the physiology of it?
More men come because they've got pain, but I will say there are some men that really have some awful looking veins. And I had one man that came to me with varicose veins that were bigger than my thumb, and they were sticking out, and they were cord-like, and they hurt him as well. So some of them, don't like the way they look, but usually there's some pain. You know, I hear a lot of people say varicose veins don't cause pain. That's not true. In fact, the majority of people with varicose veins do experience pain. If they stand for a long period of time, they hurt. Many people try to get around that. They sit down and they raise their legs up, and it makes a lot of the pain go away because you decompress the legs. Gravity becomes your friend instead of your enemy.
All right, let's do this. We got some phones lighting up. Let's take a couple of phone calls for Dr. Craig Walker, and here we go. HTV, welcome to the program. You're on the air. Go ahead, please.
Good afternoon, Dr. Walker.
Hi.
I would like to know if the cramping in the legs, which people commonly call Charlie horses, is that a venous disease?
Well, it can be veins or it can be arteries. Typically, artery disease, one gets pain that whenever they walk because the muscles aren't getting enough blood supply. Typically with vein disease, it's more common to have it after standing a long period of time. There is also, however, a situation called venous claudication. I recently worked on a young girl from North Louisiana. She was 15 years old, head cheerleader, major athlete in many different sports. And she was sent to me because her iliac vein was totally blocked, 100% blocked. And she had been told that was a normal variant, which of course it was not. It was occluded because it had been compressed. We were able to stent that. She had completely lost her ability to run cross country and other things. We were able to stent that vein and she was able to run. So she had what we call venous claudication because blood wasn't returning when she would run. So it is important for the doctor to see it. The big difference is vein problems, typically the leg swells. Arterial problem, it usually does not.
Okay. Okay, caller, does that answer your question?
Yes, it does. Thank you.
Thank you. Bye-bye.
Okay.
HTV, welcome to the program. Your question for Dr. Walker, please.
Yeah, Martin?
Yes.
Okay. Question for Dr. Walker. Dr. Walker, I had a fistula put in my arm for dialysis, and it robbed the circulation to my hand. And I'm fixing to have to go get my index finger cut off on that left hand. I don't feel like I have good circulation in the rest of the hand. Would there be anything that maybe y'all could do with that, or should I go make an appointment, or?
Yeah. Certainly you should check the circulation. What a fistula for the audience is an artery is connected to a vein. So an artery is connected, and that, because it's under high pressure, without the capillaries in between, makes the vein blow up. And so during dialysis, the dialysis nurses can stick this much bigger vein and they can withdraw fluid. Now, as you might imagine, if you've got downstream blockage in the artery and now you've given it a low pressure to run off to, it will steal some circulation. So it would be very important to check to see what is the downstream circulation to your hands. If you've got other blockages going down to your hand, then perhaps something can be done to help that. You can do an angiogram and see that. If it is purely a steal phenomenon where maybe a little too much blood is being diverted, sometimes surgeons can revise those to get blood back to the hand. There's some work going on right now in several places looking at being able to regulate that amount of flow. Most of the time, though, almost always, if someone starts to develop the kind of ischemia that you're talking about, where you could end up losing a finger, there's usually some downstream disease, and perhaps simply fixing that might help. So it might be worth your while to have that evaluated.
Okay, caller,
Okay.
any other follow-up questions?
Well, no, he ended up going in and tying the fistula off completely, but it was too late to save the finger.
Yeah.
But I still have some numbness in my fingers on the rest of the hand.
It might be wise to have an angiogram done of your hand just to see what that circulation looks like. You know, there are a lot of these, the vessels in the hand get smaller and smaller, and a lot of those one cannot bypass. But often things that still can't be bypassed can indeed have angioplasty or other things done, because we have tiny, tiny balloons that go all the way down to 1.25 millimeters in certain cases. So we can get down to awfully small sized things sometimes and really help. I worked on several ladies last week with arterial disease who came in with black toes and really thought they were going to lose the entire limb. I saw them both back today, and both look like they're not going to even lose a toe, much less the whole limb.
You have done
Doc,
some incredible work in that.
I'm a CIS patient, and I see Dr. Sole in Galliano. So should I make an appointment with him and get him to refer, or make me an appointment with y'all in Houma, or?
Yeah, I think either of those would work. I would get that blood supply assessed, though. When a digit turns a color that it shouldn't be and is cold, it's worthwhile checking out. It means there's a circulatory issue. That can be embolic, in other words, a clot could have formed and gone out there, or it could just be flow related. There's just not simply enough flow to keep the tissues alive. that's usually something we can do about that in either case.
All right, caller, thank you so much for the call. We appreciate it.
Okay, looking forward to seeing y'all. Bye-bye.
Thank you. Bye-bye. Let me ask you this, Dr. Walker, and the best way I can make a similarity would be a mechanic. You go to a mechanic, your car won't start. He could look at the battery. He could look at the alternator, make sure the battery's not charging. He could look at probably 4 or 5 different things of why your car's not starting. Somebody comes see you, like the caller just said, he's having problems, or somebody has neuropathy, or their ankle's swelling, but they just had an angiogram. You've really got to know the whole history, but then you really got to, it's like a roadmap, isn't it?
You do. And it's not so dissimilar to being a mechanic. The one thing that is dissimilar, though, if your car breaks a second time, you can get it worked on. If the body does, you might die.
Right.
And so you have to really be meticulous about making sure you assess each and everything. And even when you come up with one cause, you have to make sure that you've looked at the other things and said, gee whiz, it's not maybe a second cause. Whereas most things are caused by a single cause, and you make that diagnosis, you're on the right track and you can deal with the problem. Sometimes there's more than one thing, and you have to be cognizant of that. So I think it's one of the things that I really do love about medicine, because you really do have to apply yourself. It is detective work in the greatest sense. And when done right, you end up with really gratifying results for you and the patient. It is incredibly exciting, like in these patients that I mentioned, to be able to take someone that was in severe pain and who thinks they're going to lose their whole leg, and in a day change that whole course and have them save that leg. It's really a wonderful feeling.
Y'all have done some incredible things in that field. And let me ask you, in all the years that y'all been not only performing these, but doing the research, is there a pattern that develops where you can say, all right, this is going to happen, or as in any other science or technology, that sometimes a curve develops where you go, wow, I never saw that happen before?
Absolutely, that's the case. The biological systems in human beings are different, each and every one. And the same lesion that you may see in one patient, another patient behave entirely different. They behave differently because there are different levels of thrombogenicity or likelihood of clot. There may be different levels of outflow. There may be other things going on in the patient, other disease processes.
So you really have to know your patient.
You really do.
Yeah.
And, people like to think that this is such an exact science, though. I try to make people understand it's really still an art, not just a science, because there are a lot of things we simply cannot control. And a big part of what we do requires communication between the physician and the patient as well. We have to keep that ongoing communication, or else there's a big problem.
And before we go to the break, even down to the medicine, somebody who may take 100 milligrams or something, somebody else takes 75, somebody else takes 150, you just have to find what works.
And you forgot the third part, and some may not take the medicines they were given at all. And that's a big problem sometimes,
That
too.
is true. All right, we're going to take a break. We'll come right back. Don't go away.